Hi, everyone. Welcome to tonight's webinar. I'm going to go through a few housekeeping items before we start the program. Next slide, please. If you're having any technical issues, please try refreshing your browser. If that issue persists, please do not hesitate to contact the administrator in the chat box located on the right hand of your screen, or emailing Lindsay or lbooker@fusionmdnetwork.com. If you are having trouble hearing, please check your volume. Ensure that you are not plugged into a headset. And if you're using a computer, please check your audio output device. Please note that all participants will be muted throughout the presentation. If you have any questions throughout the webinar, please do not hesitate to write them in the questions box at any time. Now I'll be passing it off to Jennifer. Thank you.
Good evening, everyone. I guess it's afternoon for some of you. My name is Jennifer Stretton, and I'm a member of the CANIBD Steering Committee, and I would like to welcome everyone to tonight's event. For those of you who are not familiar with CANIBD, it represents the Canadian Inflammatory Bowel Disease Nurses Group in Canada. We are a community of practice within the Canadian Society of Gastroenterology Nurses and Associates, and we are also supported by Crohn's Colitis Canada. CANIBD's vision or goal is really to ensure that those living with IBD in Canada are receiving high quality nursing care within their multidisciplinary team. CANIBD has a number of initiatives available for new and experienced IBD nurses, and I really encourage you all to go to our website to take a look. One of the initiatives of the group is to provide educational events throughout the year to our members. I am certain many of you have been impacted with the changes COVID-19 has had on our continuing education, and CANIBD really is no exception. This year, we chose to roll out our education events online through a series of webinars that will take place from September through to the spring of 2021. If you're interested in receiving the CANIBD newsletter and notification of these events, please contact us at canibd@crohnsandcolitis.ca. So I'm sorry, that's canibd@crohnsandcolitis.ca. Could I have the next slide, please? I'm thrilled to be here tonight to launch our first webinar of this series. I'd like to thank our generous sponsor for this evening's event, Takeda Canada. I'd also like to extend a special thank you to Catherine Finlinson and her team from Takeda Canada, who have worked really hard to share this program with us. I'd also like to give a warm thanks to Emily Cordeau from Crohn's Colitis Canada, who worked so hard to make these events happen. Tonight, I'm pleased to welcome Greveson and Lorraine Grover from the UK to share with us their experiences and insight on sex and IBD. Kay works at the Royal Free NHS Foundation Trust, London, as lead IBD clinical nurse specialist and nurse prescriber. She has gained international recognition as past chair of the European Crohn's and Colitis Organization. She is founder and chair of the IBD Passport charity, which aims to support and educate people to travel with IBD. She is widely published in a variety of medical and nursing journals and has authored chapters in several IBD textbooks. Lorraine Grover is a psychosexual nurse specialist. Her expertise is in managing male sexual dysfunction, and she has a special interest in caring for patients diagnosed with prostate cancer and, whenever possible, their partners. Sexual difficulties can have both psychological and organic causes, and she is able to consider both aspects of management. Lorraine has a diploma in psychosexual therapy for several years has worked in the NHS, totally providing nurse-led erectile dysfunction clinics at St. George's Hospital, London, and Wycombe Hospital in Buckinghamshire. Lorraine now provides a private consultation service to help men and women overcome difficulties with sexuality and sexual function, an often underestimated area of care. She achieved a Developing Practice Award from the Queen's Nursing Institute to develop an information package for patients and partners regarding erectile dysfunction. This can be viewed at her website, www.lorrainegrover.com. She is treasurer and trustee of the Sexual Advice Association, formerly known as the Sexual Dysfunction Association, and specialist advisor to the Macmillan Cancer Support, Prostate Cancer UK, and Cancer Research UK. Lorraine lectures nationally to patient groups and healthcare professionals. She also features on the Macmillan online community Ask the Expert section, answering questions relating to male sexual function and cancer. She is a member of the British Society of European Societies of Sexual Medicine and the College of Sexual and Relationship Therapists. Oh, I need a breath after all that, Lorraine. Following tonight's webinar, you will receive an electronic next slide actually, please. Following tonight's webinar, you will receive an electronic interactive patient counseling tool that you can use in your practice. You'll also receive a certificate of attendance and an online evaluation. And we really ask you just take a few moments to review the evaluation and send it back to us to show us how we can make things better or just simply how much you enjoyed tonight's event. Sexual health can often be a difficult conversation for both patients and healthcare providers to initiate. And we hope by the end of tonight's session, you'll be more comfortable in facilitating sex-related discussions with your patients. Now let's get to it. Let's talk about sex, okay?
Thank you very much, and thank you, Jennifer, for the kind introductions. It's a real pleasure to be invited to speak on this webinar. So to start things off, I want to dispel a few myths and to talk about a few misconceptions that there is regarding sex and sexual function and inflammatory bowel disease. Slight technical function here, it's a bit more minutes. So one of the myths, well, is it a myth or a fact that having a diagnosis of inflammatory bowel disease impacts the body image of up to and over 50% of patients? Interesting thing here is this is both a myth and a fact. So research has shown that having a diagnosis of IBD can impact the body image. And there was a survey of over 200 patients which found that over 51% of men reported an impaired body image. And this is possibly something different to what you would expect, where you would think that maybe it is women. Obviously, with women, this figure does rise to a lot higher. So when we're looking at what patients will talk to us about, will patients bring up the topic of sex with their healthcare provider if it's something that's important to them? And again, this is something that there's both a myth and a fact surrounding. So less than 1 in 5 patients and also healthcare professionals report having discussions on the impact of sex. And also, when there's a qualitative survey done, patients reported that they actually felt that sexual issues were ignored by healthcare professionals or often handled badly. And I've noticed this in clinics as well, that I've seen patients or where they've come to me after they've seen one of the consultants and they felt that maybe they weren't able to discuss this, and then they've come to myself for a little bit more advice. The study also highlighted the fact for holistic patient care and the fact that really we should be asking our patients, or at least having the relevant tools and expertise to be able to handle questions that patients might ask. Can therapies for IBD impact on sex? I think a lot of us would agree that that is the case, especially as the audience today are kind of advanced nurse specialists. There are quite a few different ways that therapies for IBD can impact on sex. Steroids are well known to affect satisfaction, libido, and also body image, especially with the impact of things like weight gain and mood changes, where quite often patients won't really feel in the mood for sex. Obviously, patients who are on steroids often have a worse disease at that time, And so one of the last things on their mind is to feel sexy and to want to have sex with their partner. Surgery can often mean that certain sexual positions are impossible. And again, there's a less desire if you are unwell or if you've had surgery to kind of have sex. And there are also other therapies within IBD that can impact on sexual function. The main ones are the ones that we spoke about, which are the steroids as well and surgery. Another misconception is regarding gay men and the fact that there's a misconception that all gay men have anal sex. This is a myth. In a recent study in America, less than 40% of gay men said that they had anal sex in their most recent sexual encounter. And when you look at heterosexual men and also partners and women, found that actually over 20% engaged in anal sex. So it's a misconception that only gay men have sex. It's something that needs to be discussed with all of our patients. Patients with a stoma will always have more difficulty with sex. It's something that is a misconception, sometimes with healthcare professionals, but especially with patients who are going to undergo stoma surgery. But this is a myth, that quite often patients who have a stoma, because of the nature of the fact they have a stoma, they don't have their active disease and they're not unwell with their Crohn's disease or ulcerative colitis, often have a better libido and feel more sexier and feel that they want to engage in sexual intercourse. There is obviously sexual issues regarding surgery, and especially in women and young men who have pelvic surgery, there is a risk of fertility and there is a risk of erectile dysfunction. And this is something obviously that really needs to be discussed carefully and sensitively with all patients. So now we're going to lead on to Lorraine. So the main part of the talk where she's going to impart us with her knowledge and a few interesting facts regarding sex and IBD.
Thank you, Kay, and thank you, Jennifer and Takeda, for inviting me along this evening. If we move on to the next slide, that would be great. Thank you. Whilst we're moving on to the next slide, you can see in the room that I'm sat in, I've got some icebreakers, hopefully. And if we move on to the slide again, the next slide, think about normalising the conversation in your clinic with the team. If we normalise the conversation and we ask everybody about their sexuality and sexual function, we don't pick out certain people, whether they're in a relationship or not, what their age is. If we've got things in our room that, and you can see on the slide here, the rainbow, I've got a rainbow here behind me on the desk, that helps to broach subjects that I'm open regarding sexuality. And I have had patients speak to me about their sexuality they may not have shared with the surgeon or other healthcare professionals. And you alluded to something about that just now, Kay. Considering the gender and the culture and the language for the patient, that do you understand what they're saying to you about their sexual function and their sexuality? And also, if you're describing things to them, are you making it clear for them to understand? I have a penis on my desk often in the office, and it helps me to identify the names of certain parts of the penis, the head, the glands, whatever the language is. If the patients have got pain or not, or they can't get it up, they can actually point and show me. So having things in your room can actually really help to get the conversation going. If we move on to the next slide, please. If we've got some validated tools, that sort of makes it credible. It's not just Kay and Lorraine thinking this. You know, these are validated tools worldwide, and we've got the erection hardness score. You can print them off the internet, laminate it, have it in your clinical room. And rather than a patient say, oh, I'm sort of 50% there with my erections, or in fact, on this slide here, you can also see there's a variety of female sexual questionnaires that you can give out in your clinic. I can say to a patient, tell me on there where you are with your erectile function, and they can grade it. And it's very interesting because if you've got a partner in the room, you may find that the partner may grade at a different number, and then you get a dialogue going about what one person sees and as a problem, the other person may not. So using validated tools are great tips, and you can print them off, as I say, so you don't have to fork out anything to purchase them. The Plicit model is an excellent model. Some of you may already be asking about sexual function, which is fabulous. I think whenever you listen to any lecture, hopefully you pick up some tips. And if you're not doing it already, hopefully this will encourage you to. So with the Plicit model, the permission at the beginning here is the permission to talk about sexual function. And it's saying to patients, it's okay to have thoughts about sex. That's normalizing things for you. We will have limited information that we can share with the patient. So you may have something about anatomy and physiology in your clinical room that you may be pointing out about where stomas may be formed, or where there are particular concerns about the bowel and how that can impact on sexual function. So again, it helps the patient to realise. Do you use anything like this in your clinic at all, Kay?
So no, we don't use anything specific such as this. So we don't use a model. I will often, I must admit, kind of more recently, I have been asking patients specifically if there's anything, but it's more, I think, from a nurse's point of view, because we haven't got the experience in discussing issues. I think what I've heard from a lot of nurses in the UK is it's almost like opening a can of worms, that we can ask patients questions and ask them about their sexual function, but then it's having the tools to be able to then answer them. So I don't use any specific models, no, but I do ask about issues with regarding relationships.
Brilliant. So in fact, that limited information that you have, everybody can then pick their own bits that they want in their own toolbox or in their own clinics around the world. And then you might have specific suggestions. So it might be next time you come to the appointment, bring your partner with you. It'd be really good if you can both be in the room together, because sometimes people can catastrophize a situation and it's not really what's happening. And then intensive therapy is where you might move somebody on to a more specialised person, for example, like myself, where you're giving a much more guided, trained support for that individual or couple. So the Plicit model is a very good medicalised model to think about, and some of it you'll already be doing. And I remember as a clinical nurse specialist discussing erectile dysfunction, but thinking there's more that I feel I need to give, but I'm not skilled to do it. But actually, when I realised how much I was giving already as a senior nurse, that reassured me that I'll find out about these other things to put in my toolbox. So thank you. So if we move on to the next slide. So we've got a mention here about fatigue. Well, fatigue, not only is it relevant for IBD patients, it's fatigue for lots of us, I think, in life nowadays. And it can be really difficult to become aroused when you're tired. You know, you need to be relaxed. You need to allow the blood flow into the genitalia, into our skin, into the nipple areas, the glans penis, the clitoral tissue. And it's really hard when you're absolutely exhausted for that to happen. So I think if you're having particular flare-ups and you're talking to patients about this, is getting them to realise, to identify times of the day, the week, where they may be able to rest, give themselves time to recover, and use that time for connection. And that connection with their partner may be sitting on the sofa together, holding hands, watching a TV programme or a session of a box set. So they're being intimate. It may not be sexual, but it's sensual, and it's connecting that couple again. And it's working out when that feels right for them, because we can guide people, but only the individual will know what's best for them. And intimacy, you know, it's not always about intercourse. So as I've mentioned about sitting on the sofa or just spending time having a meal together without TV on, with phones out of the room, off the dining tables, or sitting at a table, not just on a lap, that actually is lighting a candle, creating an atmosphere of intimacy. Sensate focus, which you see on the slide here, that is a series of exercises that as sex therapists we guide people through. And by guiding people with stopping the fact they have to get an erection, they have to get a wet vagina to be able to have sex, but to be intimate, to actually learn how to relax and just explore bodies without the focus being on the genitalia, can be really rewarding and take the pressure off having to perform. Consider use of sex toys. What you do not see, and I might bring things into the screen as we go along, but I will be bringing things into the screen. I have a variety of sex toys, of lubricants, and what's been interesting for me, and I think for all of us with COVID-19, we're learning to adapt how we do our clinical work. And some of it will be on the telephone, some of it may be a video. I was very reluctant to do video consultations in my career. I've just always wanted to be in the room with the patient and picking up signals. I have found that I'm actually finding as a therapist and as a nurse specialist, I'm actually doing better work, I feel, because patients are in their own environment. They are more relaxed and they can talk about more intimate things with me. I feel easier. And I've got things that I can show them. I don't have anybody else. It was interesting when, I can't remember if it was Jennifer or Kay mentioned about healthcare professionals can have their own issues that prevent them from talking about sex. And I have worked in the past in areas where clinicians I work with have not liked, for example, the leaflets I have about sexual function in the waiting room. And that says something about them. Not me, not what I need to provide to the patient. So actually in my clinical room where I've got to move things in and out and lock things away and not have things on display ridiculously, the world's my oyster here, and the world's your oyster if you want it to be. So yeah, introducing things into your box of tricks is well worth doing. So if we move on to the next slide, please. Thank you. So, male problems. We've got male and we've got female, but I have to say LGBTQI, transgender, we must be mindful of the persons that we see, that there is a whole variability of sexuality, and we should not assume when we meet people that we're addressing people by a certain way, and give people the option. I have actually got a sexuality scale that I use, that I ask people to identify what they identify themselves as gender. For the purpose of this and talking about man problems, erectile dysfunction, well, we know 1 in 10 men suffer with erectile dysfunction, and that's a general population. So in IBD and where there's been surgery and there's a higher incidence where there's an impact around the nerve supply in the pelvic region, there are a variety of treatments to help with it. And I think often people only hear of a tablet and they'll stop at that, or patients will get tablets from the pharmacy and won't bother to ask about anything else because they don't know anything else exists. But some of the treatments that there are, you can see on the slide here, a vacuum. A vacuum is fabulous. It's been around for centuries. And how it works is the patient lubricates the base of the penis and they lubricate the base of the cylinder, and this goes over and the patient uses it standing up. So the testicles drop down, they create a seal up against the body, and they pump with this. And as you pump with this, you take air out of the cylinder and it pulls blood into the penis and it makes the penis become erect. You can hold the erection by flipping a ring that is at the base of the penis, at the base of the cylinder, off onto the base of the penis, but you don't keep the ring on for more than half an hour because you reduce the blood supply. But using this is really good because it can be used for sex. It can be used to help prevent atrophy, to stop the penis getting shorter from surgery if there's no natural erectile function. If I put this over near the mic, it's quite a loud sound. That's the suction on it. So vacuum devices are helpful. And I think it's how we explain it to patients sometimes. If we say, oh, they're not very good, which I can hear people sometimes say, I often feel, have you tried it yourself? Do you know what it's like? I encourage people to use them as sex toys, give them a name, and use it as sex play as well. There are creams you can use topically on the glans penis. Injections. Now, I know in Canada you have got Muse, which is intraurethral alprostadil, and it's a pellet that is inside this applicator, and it's pre-filled. And the patient goes to the loo and wee, so their urethra is wet, and then you twist this off the end, and in here already is a small waxy pellet about the size of a grain of rice, and this slips into the urethra. And then you push that down and it leaves the waxy pellet in the penis, and then wiggle it back and forth, throw that in the bin, massage the penis, and that can help a man get an erection. So that's intraurethral. And intracavernosal injections, alprostadil, it's a very fine needle. You may be able to just see it against the light there. It's very small. And I think when people think of injections for erectile dysfunction, they tend to think of long needles, you know, intramuscular size, but they're not. It's very small, just slightly thicker than an insulin needle. And you inject into the shaft of the penis at the base, and within 5 to 10 minutes with the correct dose, but you must start with a small dose, you can get an erection. And you certainly don't want an erection to last more than 2 hours. That's a medical emergency called a priapism. But lots of treatments there, and very much worth talking to patients about. The relationship status is interesting. I think sometimes if people, I often say, are you in a relationship? Or when were you last in a relationship? Because that will give you some idea of what's going on for that person. People don't just present with IBD or just ED. There is a person attached. And knowing a little bit more about what's going on will help you about the psychology of what's going on. And we are doing that often in nursing. And we feel like we're not trained to do any more about relationships. But actually, we can learn quite a lot when we just start to put our toe in the water and you ask more and more. It becomes easier. And then you've got more confident with it. And you might do some extra training. Because there often is a psychological component. And I just think we underestimate the psychosexual side of things. I think we may have gone too far the other way, where we think it's all organic and we're not addressing psychosexual. So if we move on, please, Kay. Thank you. For females, if we click onto the next slide here, vaginal dryness, it can be a big issue for a lot of the ladies that you see. Lubrication can certainly make intercourse or self-pleasuring, masturbation, more comfortable. There's a variety of lubricants available. Be mindful for people that some lubricants can irritate the tissue of the vulva, and there are organic lubricants that you can get. There can be water-soluble, silicone lubricants stay longer, wetter for longer. And if people are using toys, sex toys, you shouldn't use a silicone lube on a silicone toy because you may damage the silicone toy. This is one type. Do you remember the rabbit? I think I never watched Sex in the City, but I've heard how good it is, but the rabbit featured on it. This is a rabbit, a different style of rabbit, and this can be used around the clitoral tissue, and then here, this can be inside the vagina. But for some sex toys, they won't be going in a vagina. This is a sex toy here where it's to do with airflow. So this goes over the clitoral tissue and it just gives this pattern of air. So it's quite a new design of sex toy. And they vary in prices. A lot of sex shops or online services can be really helpful when people are trying to decide what to get. This is a vibrator that looks like a pebble. So again, it can be used on the body, it can be used down the shaft of a penis, it can be used between the legs of the vulva, which is an erogenous zone. And I think if people actually, when you've got IBD and people are anxious about how their body will react, if you self-pleasure and explore and encourage patients to do that, they can identify themselves what may be not right for them or what feels different, and then tell us about it, so hopefully we can direct them to the right information. It's amazing how many people aren't necessarily aware of the vulva and where the clitoris is, the urethra, the labia. So some simple anatomy in your clinical rooms can help with that and help to identify any problems that may be occurring. Any leakage, certainly menstrual pads, underwear, knickers that will absorb leakage can be really helpful. Have a towel on the bed. I think it's far better to help guide patients with what they can use rather than the patient avoiding sexuality and intimacy. Having a bowl of water with a flower head and something warm to dry things with is something to be encouraged, rather than feel that they're dirty and they shouldn't be doing anything. Thank you, Kay. We move on. There certainly can be an impact on a relationship if a patient's in a relationship, but sometimes people are not in a relationship and they're fearful of forming a relationship. Having a look at the information that's available, the leaflet in the middle, the heart of the matter, great leaflet. And I don't know if you want to contribute there at all, Kay, with the input you have in the UK with Crohn's and colitis and the information sheets there. Because the beauty now with online and accessing things, the internet's opened up things to us all. And I think sometimes people can feel very isolated and they may need some guidance on how they broach the subject with their partner. Did you, I don't know if we lost you there, Kay, or did you hear any of that? Okay, okay, I'll carry on there at the moment. I think sometimes the patient may feel that there is an issue in the relationship, and it might be something about their body image, it may be about smell, how they're perceived, are they a good enough lover? But actually, that may not be really what the other person is thinking. So I think for people to be able to have the option to just give themselves 10 minutes once a week to touch base with how they're feeling since they've had some input and being able to talk about their relationship, how that can help them. And there are some good books around. There's a great book that's recently come out called Mind the Gap. There's one about male sexuality, the new male sexuality, an American sex therapist has written. So again, I will guide people to fact sheets like we're seeing here on the slide, some books, so they feel like they're being involved in their care. And some of the stuff that they'll read about, they may be pleasantly surprised they may already be doing in a relationship, or they're not and they feel they want to address it. And now they know what to do because they've been reading about how to do that. Because it's really about empowering our patients. Thank you. Do you want to move on to the next slide, Kay, please? Now, anal sex is an interesting area because, again, it's a little bit like we saw earlier on when Kay went through the myths and misconceptions on facts. And on the slide that Kay showed, I've made a note of it because I think it is quite interesting. As a sex therapist, I will routinely ask about anal sex in my history. And most of the time, people will not be participating in it. But the study on the slide at the very beginning was more than 20% of heterosexual men or women reported anal sex in the last year. And we know it's been on the increase, but sometimes there's a lot of shame and fear and guilt around sex anyway, and there may be particularly around anal sex. The anal area's got lots of erogenous zones, as an erogenous zone, there's lots of nerve endings around there in the perineum, So it can be a really enjoyable area to be touched. But we need to remember about practicing safe sex. Lubrication is really important, and you can get anal lube, which tends to be thicker lubrication. We should avoid rather making assumptions about people's sexual behaviour and habits. And sometimes it might be a case of exploring different ways of being sexual with a partner. If we can't address the impact of a sexual difficulty, how could we open up the conversation? If we don't address the subject, how can we? So again, it's going back to what you feel comfortable in asking about. So you may not initially start off asking about anal sex, but certainly with IBD and the area that you're managing, it's very relevant to be asking about sex play. Would they like to share with you anything about sex play? Do you have permission to ask them about sex play? And again, we've got some information here that you can see about IBD and anal and oral sex. So would you like to comment at all there, Kay? No problem. The reason why I asked Kay that was because we did a presentation earlier on in the year when we could do meetings at the NECO meeting, and it was really helpful when Kay was able to share some of her clinical practice with me. But you know, that's what we will be here for anyway, with any questions that you may have that you want to send to us, or any questions at the end that you may want to ask us. So we'll move on to the next slide, please. I love this slide. It reminds me of the Mick Jagger t-shirt, Rolling Stones thing. It's great. Now, again, oral sex gets spoken about. People watching porn. Porn can actually give people an odd perception of what sex should be like. Oral sex often takes part in porn. Pubic hair's often not there. People are usually moaning and groaning and screaming from the rooftops. And that's not always what real sex is like. The media can portray things in different ways. People should not feel pressured and doing something that would make them feel uncomfortable. It might be that someone wants to share a fantasy about oral sex, but there's never been any dialogue to do so, or they've never felt confident to do that. And I think when there's any ill health, such as IBD, it gives people an opportunity to think about and talk about different positions for sex that people may not have done before. If people have a stoma, it's important about emptying before sex. You can get temporary plugs. Using a dental dam is important. I've got one here, and it's a thin, this one's banana flavoured, and it's a thin latex piece which you just put over the opening that you want to give oral sex, whether it's rimming with the anus or it's the vulval area, and it gives you an area of protection, and that's what a dental dam looks like. So it can be exciting, it can put people off, people need to feel relaxed, and that's what that dialogue, hopefully, between the patient and their partner is about what turns them on and what doesn't, or what they want to explore doing. So if we move on to the next slide, please. Yeah, so I mentioned earlier about certain pornography, and people often have got no hair, so penises look bigger, and for females, they might have particular styles. I've got a patient actually who likes a particular style to his pubic hair, uses his vacuum device, and he's grown to really feel quite sexual using a vacuum device and having his hair trimmed. It helps him if he's got any incontinence, that he feels cleaner. So that's fantastic. He's worked something out that works for him. Underwear can vary, wearing crotchless knickers or specifically designed underwear with a strengthened area around where the stoma is can be really helpful. Using bathing water, you know, if you're not worried about leaking or any smells because you're in water, you can have sex play in water. Having a bath before you're being intimate may be something that I would often encourage with sensate focus, that people feel clean, that they psychologically feel they've washed the day away, they're setting themselves some time to be intimate. Do they feel happy being naked? Asking those sort of questions will give you an idea, and watching their response or their response with each other will give you an idea of what's happening for an individual or in a relationship, watching the facial expression. Bathing can be used as foreplay. Skin is a massive erogenous zone, and touching it, you know, feeling clean or the smell can be evocative. Anything to help the person relax with sex is important. So putting skin cream on that reminds you of a holiday or great experiences you've had with your sexual partner that you'd forgotten about because ill health sort of all got wrapped up in things feeling very awkward and difficult knowing what to do. Get people to think about their senses, sight, smell, sound, taste and touch, because we use them all the time when we eat. We use them frequently throughout the day, and we can use them in sex. So again, you can use tools like this in your clinic when you're talking to patients. So I think actually that might be the last slide for me at the moment. So
I think it is, and sorry, I had a few technical issues earlier. My microphone wouldn't work.
No problem.
I suppose before we go on to the next section, one of the questions I did want to ask you, Lorraine, was, you know, how do we as IBD nurses start the conversation? What would be your number one-liner, should I say, that we could say in clinic to open up that dialogue?
Thank you. Yeah, I would say we know that IBD impacts on sexuality and sexual function. So we ask all our patients, and we want to help you with that. Please let us know and we can do something about it. So you're acknowledging that we know that it's fact and that we're there to listen. Because the first time you mention it, somebody may feel startled and doesn't want to talk about it and has to frame in their head, do they want to share that information? The next time you see them, you can either raise the subject again and say, oh, remember when I mentioned that to you in clinic, and maybe have something in your like holistic care needs or something that you can do a checklist with. Please let me know, or I'd like to give you this questionnaire to fill in. So we have a record of what's going on for you, because it's important that this care is holistic. So I would say to mention it like that. And then
it's a good idea, actually. It's a good idea, actually, and it reminds me of something that there's a couple of nurses in the UK that pioneered, and really simple idea is before patients come into clinics or while they're waiting in the waiting room, have a list of what are the top 3 things you want to discuss today, and have a list of maybe a few prompts of things that include relationships or sexual function, and then it at least then prompts patients and almost gives permission that they can talk about it, because I think sometimes patients feel that maybe they can't, and that consultations are very much symptom driven rather than more holistic. I think that can sometimes be a perception.
Yeah, and I think if people do comment on that, it should be actioned. I think sometimes it gets filed and then nothing happens with that information. So I know within an MDT meeting that I'm in, I'm trying to encourage that we get some documentation. We do about pathology and we do about blood results. I feel like we should be putting in about sexual function, because it is part of human behaviour, most definitely, yeah. And I've got 2 slides to show before we finish, 2 additional slides I think are important as well at the moment, which may give a little bit more on that too.
Oh, so if we go next on to our final thoughts, and then we've got an opportunity for people in the audience to ask questions, which I'm sure there's plenty of questions around. So when you're looking at, I suppose we kind of alluded to this in the last question that I asked Lorraine. So when we're looking and we have patients in clinic and we're looking to support them, I think it's important for us to familiarise ourselves with what information is available. And there's useful resources, for example, the Inflammatory Bowel Disease Nursing book, which is on the slide here. Also, national, international charities have got a lot of information regarding relationships and sexual function. So I think it's important to know what information is there. If you do feel able to, get some sort of a little toolkit together. It doesn't necessarily have to be something that's as in-depth as what Lorraine has, but just things and prompts that can make your life easier as an IBD nurse practitioner talking to patients in clinic. Even if it's something like what I suggested earlier, a checklist that you can give to patients before they come in to see you, which prioritises the top things, or at least gives them the permission to talk to you about things other than their day-to-day symptoms. It's also important to be able to signpost patients to information, resources that can help them. An example is going to be given at the end of this presentation from Takeda, where we're going to be able to show you a useful resource that you can use practically in clinic. And as I said, it's good to invest in a box of tricks, no matter what that is, just to be able to make your life easier. Now I'm going to hand on to Lorraine, talking about the multidisciplinary team.
Yeah, going back to the PLISSIT and a bit of what we've just alluded to now, Kay, that actually with that PLISSIT model, and I'd put in about further input, I feel really having a sex therapist would be part of a multidisciplinary team could be really helpful, because I think professional accountability, confidentiality, training and language and supervision, it's mandatory. I have got guidelines to follow, as all sex therapists do, as we do in nursing. And I feel there's a lot that you can certainly do with the patients without the need. But I do feel the bigger picture going forward for care, we're improving all the time. And I do feel sex is a difficult area to talk about. I felt that when I started. So in Canada, you know, look on the website of ASECT, the Canadian Counselling and Psychotherapy Association, which is a bilingual service. I know we've got a few delegates on tonight from the UK, College of Sexual and Relationship Therapists and Relate. They are, COSRT is my professional body as a sex therapist. So just think about maybe how in your MDT, you may want to look at bringing about some change. Also, when you mentioned about international fact sheets, for example, Sexual Advice Association that I belong to, we've got fact sheets for men and women. We've got a confidential questionnaire that people can fill in online, and it will guide them to the sort of questions you can ask your healthcare professional or a doctor, and also a fact sheet, and they're all free. So I think that's really important. So that's one slide. And then the next slide before we end is about COVID-19 and sex. And we must be mindful of the WHO and about self-isolation and social distancing. People definitely are becoming more anxious and worried. And we've got people who are single, who are wanting to form relationships. I really feel we have got to flag this up. I'm doing it a lot with the clients that I see. And I think if we talk about COVID-19 risk, as we would do about safe sex with a partner, that we have consent, that we communicate, not having face-to-face kissing, adapting how we're intimate. In some ways, it may be that we would be getting intimate by getting to know somebody more. I'm finding I'm encouraging people to be more sensual in getting to know people before actually meeting people, or trying different sex positions so that you've not got face-to-face touching. And certainly if you've got any symptoms, you wouldn't even be considering having any sexual activity, because we know COVID is spread through direct contact with respiratory contact. So it's really being mindful of this, But also we do want to promote health and well-being, and it's good for our mental health. The safest sex is masturbation and self-focus, and I think it often gets thought of as it's a male thing to do, but women can enjoy masturbation too. So that's a great thing to go out on, to encourage people to masturbate. I'm a strong advocate of it, and sometimes we have to say that to people because there's myths around masturbation and they'll go blind, or I've been told I'll get hairy hands. Well, let's dispel these myths and encourage people to have safe sex. So.
Thank you. The last one's a new one on me. Brilliant. Thank you.
Oh, well, thank you so much, Lorraine and Kay. That was a fabulous presentation, and your relaxed manner really helps normalize the topic that's sometimes really awkward for us to address. I think we do have some questions here from the group. The first question we had was, if we are an infusion nurse and the patient has sexual dysfunction questions, we cannot answer those questions. Who do you suggest we refer the patient to?
Do you have sexual health clinics linked in the hospital settings that you're in or in primary care? Because sexual health clinics often have sex therapists or sexual health advisors as part of them. So,
there could be. I'm not familiar with them in my institution, but maybe somebody could step up and answer that question for me if they're familiar with that.
And certainly in the areas that you practice in, the Canadian list of sex therapists and sex educators, when I was looking at it, sadly my geography of Canada is poor. So much so I didn't even know about the time zones, that you've got all these different times. But actually you could see around Canada where different sexual health educators were. And so, connect with them, Zoom with them, say hello, introduce yourself, and just find out who these people are to see if you can signpost to people. Jennifer, I must admit, I missed the very beginning of is it a nurse in IBD? I missed the wording that you used. Was it?
Sorry, it was a nurse who works in one of our infusion clinics. I'm not sure if you're familiar with them in the UK. We have private infusion clinics where people can receive their biological treatments. So these nurses maybe don't feel comfortable addressing some of these questions, and she's just wondering who she could refer them to.
Oh, okay, yeah. So, yeah, I would definitely have a look on that Canadian website and ask in a sexual health clinic. You might call them STI clinics. I mean, we don't call them that here now, but you may be able to find something in your area that you can hook up with. Yeah.
Also, Jennifer, presuming with the infusion nurses, would they be linked in some way to a regional nurse practitioner, or would they be able to refer the patient back to the physician to kind of talk to, maybe ask them to take the lead on it? Or does the nurse usually work independently just in the infusion unit?
I think our nurses in the infusion clinic really try to offer a lot of support and education to patients, but yes, often some of these more difficult questions, or if they're more medical based, they refer them back to the clinic, either to the nurse practitioner or to the gastroenterologist they're seeing.
I mean, I think that's probably, the slide that I had before is, not every nurse is going to feel comfortable to answer those questions. So it's mainly just knowing how to signpost the patient or who they can ask themselves in order to have that knowledge. So maybe, ask the nurse practitioner that they work with, or like a regional nurse practitioner. And as Lorraine said, if there is, like in the UK, it's often in the community in the UK. So clinics where patients can go if they do have a potential sexually transmitted disease, or for example, if they are having their yearly gynecological checks, that there are clinics. I'm not sure whether there is something like that, whether it will be with the family GP. But yeah, they're just being signposting, I think, is useful. Maybe just being aware of if they don't have the answer and feel comfortable, who to then refer on to.
Is there any webinars or recorded presentations similar to tonight that is available for patients, or are they geared more to healthcare workers?
It's a good question, actually. I think mainly they're geared towards the ones so far. It's a topic, particularly in inflammatory bowel disease, that hasn't been discussed that much. I mean, the presentation that Lorraine and I gave at ECHO last year was one of the first ones, really. It's almost like an emerging subject that people don't really talk about, but I think it is something that patients would find really interesting to be able to ask questions. 100%, that's a really good point.
Because they can read.
Yeah, sorry. I think
I was just going to say they can read it on a pamphlet, but listening to Lorraine and you speak, it just makes it so much comfortable.
And I think a webinar is great because you've got anonymity. So I gave a talk in February time, January, February, to a Crohn's and colitis group locally in England. And 5 people turned up and 3 people were from the organisation. And they were up in arms when it was said about me going along to lecture. And should it be happening? Some of the older members didn't want it to, and some of the younger members did. And I think the beauty of a webinar is that patients can be at home and they can listen, you know, and they're not visible to other people. So I think it would be really helpful. I'm not aware of anything, but I think it would be helpful.
I agree.
Yeah.
I had one question is regarding other cultures that maybe aren't comfortable with discussing sexual intimacy and issues like that. How do you approach that with patients that maybe are from other cultures that aren't forthcoming or comfortable discussing this?
I still go for it. And I tell you what I learned, Jennifer, back in the 90s, which is when I started doing this as a research sister, and I was doing Viagra trials before it had a name. It was that long ago. And I thought this, I was in St. George's Hospital, a huge Muslim community, and I was sat in my urology clinic thinking, flip, how am I going to address sex with these gentlemen? And I started to, and they were so open with me because I'm not a Muslim woman. And so it's so interesting that I thought I shouldn't ask. The people who were really difficult for me to get to open up and talk to me about their sex lives were the non-Muslim people in Wimbledon who were very purse-lipped and, you know, didn't want to talk about sex with anybody. And I thought that was quite interesting. And I find now that actually a lot of the Arabic people that I see are very open about their sexual behaviour. But I was wrong in assuming they wouldn't want to talk to me, and I was really hesitant in doing so. So I think you just have to go with it. And if someone feels awkward by it, you can apologise, but normalising the conversation, we don't exclude anybody from being given this information. So I would go for it. Yeah, be amazing what, you know, sometimes even I feel now, blimey, gosh, I never knew that, or I didn't think they'd say that, you know. So that's the beauty of our jobs, isn't it? Everyone's an individual, and everyone's an individual for sex as well. So.
Very good. I have another question from the group. So they have a female patient with perianal Crohn's disease waiting for a ceton suture, and they're worried about intimacy. What kind of suggestions would you have for that person?
I mean, from my point of view, I would tell patients really to only engage in sexual intercourse when they feel comfortable. A ceton can be very sore, especially when it's first inserted, and patients can often feel quite kind of conscious of the fact that the ceton's there. I think lubrication is essential. What Lorraine said about trying different avenues of intimacy to start off with, just to maintain that close relationship with their partner. Be open on discussing what a ceton is, because if their partner doesn't have IBD and isn't aware, then letting them know what it is and why they're having it will make them feel more comfortable. I think as well, because of what aceton is, and obviously allows the drainage of kind of liquid from a fistula, then I think doing things like having baths together can help patients feel a little bit more clean before there's any intimacy. I think all things like that really, but I think opening the conversation and being open with their partners and trying things that they feel comfortable with is important.
And
do you
I
have
think,
anything else, Lorraine?
yeah, I was about to say about clothing that we might wear. You know, wearing something against your skin that makes you feel sexy, and it's maybe silky, or, you know, a colour that may feel good for you, than wearing something that's more cotton and scratchy and is a bit more functional, is to actually spend a bit of money on something for yourself to make you feel good about yourself. But I think a lot of women are very guilty about doing that sometimes. You know, everyone has to fit in round, and we've come second. But this is a great opportunity to do the things you've said, and maybe just think about what you can do, what you could wear that you may make you feel sexier. And it might be another part of your body that you're going to focus and highlight more that you didn't before. So, yeah.
Very good. Well, I think that is the end of our questions. I'm going to pass this over to Catherine, but before I do so, I'd just like to again thank Lorraine and Kay for just a wonderful presentation. I've learned so much, and I'm sure the other participants have as well, and I hope that we'll have another opportunity to hear you speak again.
Thank you.
Thank you.
Thank you for inviting me.
Thank you. Kay, can you go to the next slide, please?
Oops.
I just want to let the audience know that you will be getting a Let's Talk About Sex patient counseling tool. And this is an interactive, downloadable PDF. And we will be sending it to your email after the WebEx. And to the next slide, Kay, please. And just to remind everyone that evaluations will be sent for you to fill out at the conclusion of this webinar. Please consider to opt in for CANIBD newsletter. And on www.ibdinsight.ca is a medical education website for HCPs. We will be posting this webinar, as well as you will be able to get access to the PDF for anyone who is interested, and this is for HCPs only. If you would like to register for future webinars, please take a look at ibdinsights.ca and absolutely follow CANIBD, as this WebEx series will be continued by CANIBD with other amazing topics to support nurses. Their annual conference will be happening this year virtually on November 5th. And to register, the address is below, but just go to crohnsandcolitis.ca and you'll be able to find the registration there. Again, thank you so much, Lorraine and Kay from London, England, for staying up tonight for this WebEx. And thank you, Jennifer, for being an amazing moderator. We appreciate the collaboration and wish everyone the best. So thank you very much, everyone.
Thank you so much.
Good night, everyone.
Good night.